Hi, welcome to the section of cardiology. This is Dr. Jaitly. In this section, the video vignette, I'll be talking to you about, is heart failure a neurohumoral disease? And what is the treatment based on for the heart failure? Well, I'll probably give you some more updates towards the end of my discussion on this, but just in the first few minutes, I want to give you a basic concept as to how the heart failure occurs. Now, let's understand on this right panel first that this is a preserved left ventricular ejection fraction where the stroke volume is well preserved. Okay, in other words, the ejection fraction is fairly normal, and this is called a preserved left ventricular ejection fraction, or HFpEF, heart failure with preserved EF, HFpEF, HFpEF. So when you have an ejection fraction of 50% and over, it is a preserved left ventricular ejection fraction. In other words, you can have an ejection fraction of 65 and still have heart failure. Now that's a preserved heart failure, preserved systolic function heart failure. Now when you have a reduced LVEF, which means say the end-diastolic volume was 150 cc's, it ejected only 90 cc's out of it. So your stroke volume was only 60. Now 60 as a percentage of the basic volume, which began with 150, so 60 over 150 times 100 gives you a 40% ejection fraction. So that's a reduced systolic function heart failure. Okay? So a reduced systolic heart function failure is characterized by where the left ventricle is enlarged and is unable to pump adequately through the aorta. So obviously the oxygen consumption is not being met to the needs of the body. 6 million people in the US have heart failure. We have a proportionate 600,000 new cases every year adding to this pool. And unfortunately, there are 350,000 deaths every year. But just so that you know, the epidemic and the prevalence is increasing, and they're projecting about 10 million people in the whole wide US continent. So that's a very, very fastly spreading epidemic of heart failure, and partly it's because people are living longer with ailing and failing hearts, I always say. Because people are surviving of myocardial infarction, there are newer technologies that are developing, which we'll discuss here, newer drugs that have really come on board and which I will discuss here. So all of those and a better understanding of the heart failure leads to longer lives, and therefore people are dying at a later stage and age of their times, and the mortality is still there, but the fact is that the epidemic or the prevalence is increasing in the pool. Pathophysiology suggests that it is a neurohumoral disease. Why? Because we have raised norepinephrine levels in those individuals. We have renin levels which are high, aldosterone levels are high, vasopressin levels are high, vasopeptide levels are high, and the ANP levels are high. So all of the above are high, and so that's an exception to the rule that all these levels are really supportive of this heart failure setting, which means there is increased sympathetomimetic activity. The heart rate is increased. The cardiac output is being maintained, or under the circumstances of lowered cardiac output, even while the stroke volume is less, the heart rate compromises, the increased heart rate compromises to improve the cardiac output as much as possible. The oxygen consumption therefore is high. So the treatment now will depend on all of these factors you want to help support, or because they are supportive factors, no question. This is a supporting system that by which the heart failure person exists to meet the needs. But all of this is really also working of the heart, quote unquote. So we need to unload the heart to an extent. So an afterload reducer or preload reducer is very helpful. Afterload reducers classically are your vasodilators in the arterial system. Preload reduction is primarily done on the vein side, which are like the typical nitrates or alpha blockers. So let's understand. So alpha blockers and nitrates will work on the preload system, which is on the venous side. The arterial side will be predominantly the ACE inhibition the ARB, and of course the diuretics, which will be primarily on the afterload reduction. So it's very, very paramount importance that we understand that preload reduction and afterload reduction both help in heart failure patients. These are the sets of drugs that I just talked about. But very importantly, beta blockers, what they do is they reduce the oxygen consumption and by decreasing the heart rate. So we have carvedilol and metoprolol as two prototype drugs which really help in the setting of oxygen consumption reduction. But then we need to also reduce the peripheral vascular resistance in these patients. And the peripheral vascular resistance is high. So alpha blockers and nitrates are very helpful. Decreasing sympathetic activity, again by beta blockers, is very helpful. And decreasing all these levels, the RAS system we call it, RAAS activation, is helped by ACE inhibition, by ARB, aldosterone antagonists like spironolactone and propranolol we have, and then we have diuretics, of course. Now, if there are arrhythmias, like let's move to the left side of this panel. If there are arrhythmias within the heart, then one can attach a pacemaker, especially if they are very, very ventricular, rhythmic, and life-threatening. Then, especially for VTACs and previous episodes of sudden cardiac death or torsades, etc., patients get a desynchronization therapy or an ICD defibrillator. We call it intracardiac defibrillator. There are drugs one can use like sotalol or amiodarone to control the ventricular arrhythmias in the setting, or atrial fibrillation in the setting. And all of these drugs are wonderful drugs and they're approved, but they have to be used very cautiously, obviously, monitoring the levels and their dosage forms and the compliance on the patient, and of course drug interactions have to be taken into account as well, which we will discuss at several other meetings on heart failure. Now, two new drugs came out. One of them is sacubitril, and that's a neprilysin blocker which prevents the degradation of ANP and BNP. Remember, ANP, BNP are being secreted by the LA, the left atrium. Left atrium, I call it, is an endocrine organ now, because it's storing ANP and BNP in the setting of heart failure or in the setting of, say, an arrhythmia, tachyarrhythmia. So when it sets that, that's a support system, and that support system sometimes overworks the heart. So neprilysin blocker, what will do is it will prevent the degradation of ANP and BNP, because ANP and BNP are essentially natriuretic factors. So when you have ANP and BNP, you could do a sacubitril is a great drug because it blocks the degradation of ANP and BNP. Similarly, with ivabradine, which is a first HCN blocker, it blocks the currents in the SA node, which are in the RA here. So even if the heart rate is lowered to the maximum, say the heart rate goes down to 70 by using an adequate beta blocker dose like carvedilol or metoprolol. So when those drugs are involved, one can still lower the heart rate because the desired heart rate is still 60 because you're using 10 more beats per minute, which means a lot of oxygen consumption is still being not managed. So if you're not able to lower the heart rate sufficiently with beta blockers, then one can use ivabradine. Okay, so that's a newer drug that has worked on the SA nodes specifically to block the, I call it the inflow current channels in the SA nodes specifically. And last but not the least, one should be aware that on an EKG, if somebody sees a bundle branch block, a cardiac resynchronization therapy works. Why? Because say this left ventricle is moving all right in the systolic dysfunction type of heart failure, but the septum is dyskinetic, as I've shown, septal dyskinesia, and the septum moves in this direction. That means the left ventricle is not contributing. This side of the septum or this side of the left ventricle is not contributing at all. On the contrary, is derogatory to the left ventricular ejection fraction. Now, here is a pacemaker, or we call it a cardiac resynchronization therapy, with two leads, one in the atrium and one in the ventricle. And this has a coil in it and sits into the right ventricle. So as a result, the bundle branch patients who have heart failure or the heart failure patients which have bundle branches, the QRS beyond 0.14 seconds will benefit from a CRT. That means insertion of a resynchronization lead sitting in the right ventricle will help stimulate at a particular time of the QRS to make sure that the ventricle is contracting synchronously. So now the septum wall moves in and the free wall of the left ventricle also moves in, contributes to the ejection fraction, and therefore more blood is passing every stroke volume into the aorta, improving the cardiac output per se. That is the concept of CRT. Hope you enjoyed this section. We'll talk more in detail later on. Thank you so much.